Okay, so today we are talking about infection and inflammation and how we image this in nuclear medicine. It's an important clinical question because often the treatment of the patient and also the outcomes is dependent on knowing if it's an infection or a sterile inflammation, or if it's like other diseases. A lot of the diseases that mimics the same type of symptoms can be cancer or other things. And then also it's important to pinpoint where these infectious or inflammatory foci is, so that you can take proper biopsies and learn more about what is going on in the patient. So it's also quite an active area of research. Every year it changes already, and there's already new tracers being developed and implemented in the clinic. So I will just give you a quick short run through everything, and then yeah, we go from there. So the contents of this lecture will be the good old staples of nuclear medicine imaging, PET as well as SPECT. Then I will also look at some newer techniques and discuss them and maybe where they currently fit into the spectrum. So I always, also because I'm not a nuclear medicine physician, I'm a radiopharmacist. When I give the lectures, I primarily focus on the EANM guidelines, and the major indications for FTG stipulated by them are sarcoidosis, peripheral bone osteomyelitis, fever of unknown origin is quite a big one as well, and then also high-risk patients with bacteremia and the evaluation of vasculitis. As I was last week at this year's EANM conference, yes, there was also now new upcoming guidelines that will be published this year still, where they actually expanded a little bit on what can be imaged with FDG for infection. Major indications was included extra, and then also some well-described applications without sufficient evidence, and then some with unclear advantage that is still being investigated. So please keep an eye out for the new guidelines that come soon. I think they will be expanding also your nuclear medicine practice. As we know, FTG is very non-specific, and it's just focused on it's a metabolic tracer. So it images the body's reaction towards infection, inflammation, or cancer. Cancer cells, of course, have upregulated glucose metabolism and needs, but so does the inflammatory process. It also increases the body's need for glucose and energy. So the GLUT1 transporter is upregulated and more FTG is taken in. FTG is not undergoing further glycolysis, so it is trapped inside the cells, although it does go through the first metabolism with hexokinase. So this is always important to remember, but that it's really non-specific. For sarcoidosis in particular, it's important also to mention that you want to suppress normal FDG utilization. So if there is no inflammation present in the heart and you suppress the use of glucose in the normal metabolism, hence you have to decrease the insulin secretion in the patient, you will see no uptake in the heart. If you have a patient that has sarcoidosis, you will still see FTG uptake because the heart is not able to use the free fatty acids for the needs of the heart for metabolism. So you want to suppress the normal physiological uptake of glucose to the heart, because the heart uses a lot of glucose, as we all know. And then you can see if there is any other inflammation present. So the myocardial suppression protocol is really important for the imaging of sarcoidosis, and I actually sat through quite an interesting lecture at AENM about this, and the person giving the lecture also mainly referred to this article. This is a great article that you can go and have a look and save for yourself because it gives an extensive review on the myocardial suppression protocol. Here is just an example of a patient with excellent preparation. These are healthy patients, moderately okay preparation, and then also poor preparation. So of course, if you have poor preparation, the scan is useless, but then also, of course, you depend a lot on the patient to do what they have to do. So the recommendation currently for myocardial uptake decrease or for the suppression is a high fat, no carbohydrate diet, no exercise within 24 hours of the exam. As with every FDG scan, muscle exercise leads to higher FDG uptake. So also in the heart. Um, Very importantly, quality assurance. So in your facility, you should always see that at least 80% of, sorry, the scan, I guess, is at least 80% adequate suppressed. So you have to evaluate the scans very well, and also maybe your departmental protocol on a regular basis to see that the patients are preparing right, that you are communicating with them. I think particularly in areas where there is so many different needs for patients with regards to communication, it will be good if you do a really nice patient leaflet maybe, or just communication is of course key. And then maybe heparin 15 minutes before FTG administration. This increase the use of lipids for metabolism. So this is also a maybe, because I think it has been shown to be beneficial, but it's not absolutely necessary. And then any whilst things that has not been proven is the use of calcium channel blockers or isolated fasting, and definitely an unrestricted diet is not an option. Again, check out this reference, it's really amazing. The next tracer that you could use together with your FTG for the imaging of sarcoidosis is sestamib. As we know, it's a myocardial perfusion agent, so the accumulation is perfusion dependent, and then also in healthy cells that can actually trap the system maybe due to the negative mitochondrial charge and the positive cationic charge of the MIB. And this is another nice article that you can have a look at, which just gives you more additional information in cardiac sarcoidosis combined with metabolism. So I really like this image as well. Then we go into another staple of nuclear medicine, and this is one that I work with more on a regular basis as a radiopharmacist, because of course when you label white blood cells, you have to talk to the rest of the team and figure out why your patient's white blood cells did not label, or what is going on, because the patient's characteristics really influence also critically, and their disease process influence the ability of the radiopharmacist or technician to be able to label these white blood cells, because they can have different types of medicine that influence labeling, or the amount of white blood cells in the body also influences the labeling efficiency. So it's really important, if you want to send a patient for white blood cell study, that you really take into account the EANM guidelines. Again, there is a nice set of guidelines on the white blood cell labeling techniques, as well as also just the whole procedure and what is the correct specified disease that you can send the patient for the study. And it's also a lot, always osteomyelitis, infected joints, inflammatory bowel disease, but as you see, it was also already showing up on the FDG list on the new guidelines. So maybe I think in the future FDG would be a better option. endocarditis, again, fever of unknown origin, also FTG, so you can maybe consider both. Diabetic foot, post-operative abscesses, lung infections, and neurological infections. So white blood cell scintigraphy, the process. The EANM guidelines for the clinic says that you should do a general workup of the patient, which includes erythrocyte sedimentation rate, C-reactive protein, as well as white blood cell count. I did an independent study with one of my students, and really the only thing that matters for the radiopharmacist is the white blood cell count. So the labeling of the patient's blood, white blood cells are not dependent on any other inflammatory markers or possibly the disease outcome, the diagnostic criteria, but the white blood cell count really does make a big influence on the labeling efficiency. So be nice to your technician and get the white blood cell count and see that it's elevated before you order a white blood cell study. I know I had arguments with really esteemed professors that know their stuff that will still order a white blood cell study in patients with just normal white blood cell levels, but really often in the radio labeling procedure fails in the radio pharmacy. So it's also, if it's really important, you can do maybe higher blood collection, like instead of 120 milliliters of blood, you can even push it like to more, and then you can try to isolate the white blood cells and label them. But unfortunately, most often this fails. So the procedure really depends on the amount of white blood cells. You can see that I'm very passionate about this and that I struggled with this a lot. So you have this whole radio labeling procedure. I do have another lecture on YouTube on white blood cell labeling that I would ask you to consider to go and watch. It's really a nice procedure. And I also wish I had like I recorded myself doing this and I could upload this as well, but yeah, maybe in the future I will do this. Um, but yeah, also make sure that you maybe see it. If you can, I think see it in the clinic, it's also nicer to see. It's just like once off seeing it. And then of course you can then image the patient. So the rate of accumulation at the infection of is dependent on the behavior of the white blood cells or the leukocytes. If you do your technique well, the leukocytes will be alive. You also have to do quality control tests to check that they are alive before you inject them back into, or behaving like they should physiologically when you inject them back into the patient. So they will go to the site of infection, and the rate of accumulation and infection depends on where the site of infection is, how virulent this infection is, or what how high the immune response is, or the infection or inflammation, how severe it is to cause this response in the patient, the extent of this infection, what type, how the blood flow is. So of course, these white blood cells are injected intravenously and have to go to the patient's infection site, and this is also blood flow dependent, and that's why also in inflammation, the white blood cells will go there as well as infection. So it's not really always distinguishing between the two that well. And then also the therapy that the patient received. So the medicine can really influence both the lab technique, the labeling, as well as the actual procedure. So you will take a delayed image at around 3 hours, and in late images, and normally with late images, if it's still persistent, then you can see it's really infection, or if it disappears, then you have to maybe consider other options. And then always also do expanded bone marrow in cases where you think this can be influenced with the injection of technetium nanocolloids, just to also exclude this as maybe causing this accumulation of white blood cells. So I am here having the procedure of technetium radio labeling with HMPAO, but there is also indium labeling, and I think there is some PET tracers coming as well, PET radionuclides like zirconium that you might be able to use to label white blood cells. Due to the fact that you want to do delayed imaging, um, sorry, after 24 hours. Technetium perhaps is not the best radionuclide for this, but it is still workable. That is why you also should stick to the cutoff limits of the ENM guidelines that says you must inject more than 340 megabecquerel of uh, technetium tracer, which is already quite on the low side for a successful delayed image. So it's really important. But radionuclides like indium or zirconium with longer half-lives will, of course, be more optimal. But then you should also note that your more uh, the radiation of the other radionuclides might be a little bit more severe, and that can influence the viability of the white blood cells. Like indium might be detrimental to the health of the white blood cells and irradiate them a little bit more and cause a bit more cells dying off. So all of this is always like a handoff between, yeah, what is the most feasible. And of course, technetium is really inexpensive and widely available. You don't need a lot of equipment to do this labeling, so you technically can do it really in any environment. I would strongly suggest that you get a microscope to do QC afterwards, because I think often it's not being done, and I really think, especially if you are still learning how to do this, that you really have to check if the cells are viable. You don't need a fancy microscope. You can get a second-hand one somewhere, or even buy a cheap one. They are not really that expensive. You need a centrifuge. Um, Also, you don't need one that will cool down the samples. You really don't need a special centrifuge, just a normal one will do. And yeah, there is the protocol. Of course, you can always also email me if you're interested, and I can send you the detailed protocol. But first, you get your white blood cell counts, draw blood from the patient. Normally, um, we used to draw about 80 to 100 milliliters. I think it's a lot, but yeah, just to make sure. I think we did oh, at least 3 of the 20 ml syringes, maybe sometimes 4, so that's 80 milliliters. And then you let them stand so that by gravity you sediment the cells out, and then you take the plasma. So ideally the red blood cells and stuff has sedimented out, and your plasma with your white blood cells stay behind. You cannot do this through centrifuging, because then you will just centrifuge all the blood cells out. So it's really important to let it stand and let gravity do its trick. Um, then after that, you centrifuge the cells, and you then have the white blood cells, and you can just remove the supernatant. You add your freshly labeled technetium HMPAO. It should be labeled within the last 30 minutes. So normally 2 technicians will do this together, so that the one label the HMPAO and do the quality control and give it to you when you are ready. And then you add it to the pellet, you incubate it, and you do a washing step, and then you resuspend it, and then you do QC. Let me think, what important thing I now forget. No, that's it. It's really quite easy. And yeah, well, the important thing I'm forgetting is that if you can see how much you manipulate all of this, there is quite a few risks. So first, risk to yourself, because the patient's blood can have disease, or it's biologically hazardous. And then also a risk to the patient, because you have to work really sterile and you are handling blood products and all of that. So it's really important that this is done in a separate laminar airflow from your normal day-to-day work, so that you don't put other patients at risk. You should make sure that you work very sterile, that you don't put your patient at risk because you're going to work with open blood and you're going to expose all of this to the environment. So there is a kit called, I think it's a Leuko kit, where you can actually buy a whole setup that you can do this whole procedure without ever opening the patient's blood to air or the environment. And in that case, you can for sure label it in your normal LAF, but the IAEA guidelines says that you should have a separate area for working with patient blood products and radio labeling them. So, yeah, no really big equipment needed, but you do need a separate area to do this. So the quality control of the labeling is the radiochemical purity. So you have to check the technetium HMPAO that it's at least 80% pure. Then you have to check the yield of the labeled white blood cells. Now, we are not talking about a 40% yield or a 60% yield. That's not what we are talking about. It's not like normal radiochemical purity. This is purely the amount of labeled white blood cells that you get out at the other side in megabecquerels. So you need to have more than 340 megabecquerels of labeled white blood cells to inject. So it doesn't matter if you have added 1,000 megabecquerels of technetium HMPAO and you only ended up with 340 megabecquerels, and it's quite a relatively poor yield. It's not a yield in percentage, it's a yield in radioactivity amount measured. So that's really important because it is always a bad yield, to be honest. And then you have to do this microscope analysis where you stain your cells with trypan blue, and you can see here that the blue cells are dead, and these ones that has just a halo around them are alive. So you must make sure that you have a really high viability of white blood cells, and that's why you have to do this very quick and easy trypan blue cell test. So that's why I really feel strongly about having a microscope in the facility available if you do this before you inject it in the patient. Because if you inject a lot of dead white blood cells into the patient, your scan will be negative because they will not behave as they should. Great. The next technique that I'm not going to discuss in depth is the free-phase bone scan. I'm including it because it's really valuable in pediatric populations when you cannot do really white blood cell labeling. There is an adapted protocol where you can label with as little as, I think, 20 milliliters of blood, but below a certain age, 3-4 years old, it's really not feasible to do a white blood cell study in children. So a free-phase bone scan can also be valuable in that population. So you look at the blood pool accumulation and the flow and see if it's increased uptake at a effective joint or so, and then also a delayed image, and then you evaluate that. The next old school one that I want to discuss is citrate imaging. So there used to be a lot of gallium-67 citrate imaging. Gallium-67 is a SPECT radiopharmaceutical that is made in a cyclotron. It's not really available. I tried to buy it recently for research purposes in South Africa, and I couldn't get hold of it, and it's really not readily available. But it has a really nice half-life. Of 78 hours. Sorry, I had to look that up quickly because my mind is just wandering. So it has a half-life of 78 hours, which allows you to do long-term imaging. So the idea of citrate imaging was that you inject the gallium citrate 67 into the patient's blood, and over time, in infected cells, the ferritin and transferrin and lactoferrin and all of these trans transkylation will happen at these infectious sites, and the macrophages will take up the citrate, as well as it's postulated also some bacteria that uses these siderophores and things for energy. So it's been taken up into your infective cells. But this process do take time. So it was proposed that gallium-68 from your generator for PET imaging can maybe be used in a similar way. And there is a few publications, also a lot coming from Steve Pico, Pretoria, and it seems to be an option in certain indications. But the jury is still out that what indications is preferred and how it should be used. And yeah, maybe if you are interested in this, you can also talk to Prof. Marisa. So yeah, but it's also an option for imaging. And then there was a few antibodies, technetium-based antibodies on the market. All of them kind of discontinued. I think Sentimmune is still being sold for Sentimmune is just maybe a different way of labeling your white blood cells. I think a local provider there in South Africa was still selling it when I was there last year. So it is just a monoclonal antibody that binds to the IgG1 isotope, and it binds to the white blood cells in essence and then go with them, so that you don't need to anymore label the white blood cells outside of the patient, but you use a monoclonal antibody to label the white blood cells and then go to the area of infection. The problem with antibodies is immunogenicity, and that it can actually trigger an immune response in the patient. So due to that reason, the Leukoschan and Nutrispect was discontinued by the authorities. Um, and of course, also with antibodies, you can design them in a way that they maybe focus on more on specific diseases or specific infections. So there was one for the imaging of appendicitis that could have been really useful. No invasive surgery if not needed. And yeah, you can just do imaging and see if it's really appendicitis or not. But this is now discontinued due to actually patient death. So there was serious adverse events, and they had to discontinue it. So not used that often. And then we go to fibroblast activated protein imaging, which is like really the golden new thing at the conference. So I thought that it's really important to start mentioning FOPI because it is coming. There was various investigations looking at things like hip infection, Crohn's disease, lung disease, amyloidosis, and there's quite a few maybe larger cohort studies where there is even 103 patients, 83 and so forth, and it all seems quite positive. So fibroblast activating protein is really easy to label. It's as easy as PSMA or dotatate. So I'm sure it will definitely come into in the future. It will come into play, and the research on this is far from over. Um, Also, they investigated it for COVID-19, for long-term COVID effects, and so on. So there is also a review there down below if you want to read more on FOPI. This is the structure of FOPI. So you will see it's not a peptide, it's a small molecule. And then it also has the chelator to which you can label gallium, and then of course also your therapeutic isotopes. So this will also bring into question the use of FOPI in cancer versus FOPI in infection or inflammation. And again, like FDG, FOPI is maybe a non specific radiopharmaceutical, but now it also has the additional selling point of being a theranostic. So now you have a maybe a more non-specific theranostic. You could possibly, I guess, also use it for the treatment of inflammatory conditions. So I think it's quite an interesting molecule, and we will definitely hear more about it in the future. Then I wrote a review on RGD and integrin imaging, and there was all of these options that it could also be used for imaging infection and inflammation. We wrote this back in 2021. It's not moving forward that quickly, but it might be an option if you deal with additional blood vessel formation in certain more chronic inflammatory diseases and also chronic infections. So it's also something that one can consider, especially if you have a gallium radiopharmaceutical producing radiopharmacy on site. Then there is multiple research in using peptides that target bacteria specific, because it's still a question of whether you want to just target general inflammation and infection, or you want to go bacteria specific. And it's still not really developed to a point where we can say that it is possible. But ubiquitinin was one of the peptides targeting bacteria specific that was the most developed thus far. So I thought to just have it as an honorable mention. This is also a review that was focusing on the new radiopharmaceuticals that are developed preclinically, and people are working on some more bacteria-specific tracers. I'm not going to go into more depth, but if you want to read on this, you're more than welcome. So I don't need to preach to you as the clinicians. But yeah, the patient will also, of course, inform your decisions, and it's all about the symptoms of the patient, their other clinical workup, as well as the various nuclear medicine studies that you can have. Stick to the EANM guidelines. I think nuclear medicine in infection and inflammation is one of the modalities that can help the clinician to make a choice in the clinic on how to treat the patient. But thus far, it cannot really stand on its own and make a definite diagnosis, but it's a really important investigation that can provide added benefit to the patient. Stop the recording.